So we're dispatched to a patient that's been stabbed in the upper chest on the right side and shot with a 22 through the bottom jaw. Being an assault. PD's cleared the scene. We have fire and backup. Clear to enter. We have PPE on appropriately. As soon as we make contact, general impression would be a male that's been, or a female that's been assaulted. Blood everywhere in the scene. So we got, she's not alert. So we, hey, can you hear me? Can't hear me. Doesn't respond to pain. So GCS of 3. We're gonna go ahead and look for obvious life threats. So obviously we have a shot through the jaw. So we're gonna go ahead and have a fire and manage the C-spine as well as hold pressure. Second time. We moving down, we see an obvious stab wound. So it'd be like right here. We're gonna manage that, clean it, hold pressure, and apply an occlusive dressing. And we would go ahead and check the abdomen, legs, PMS. Once we've stopped our bleeding, we got an occlusive dressing on. Go ahead and manage. Got the head. He's going to do a jaw thrust, open the airway, make sure that's open. So the airway is going to be open. We're going to go ahead, bypass OPA, go for an I-gel. We'll say an Accepsin I-gel, tube tamer on it, and BVM ventilate. Trying to think how to. So we do have a pulse. He's breathing and everything. So we know he's got the pulse right now. So we know he's at least 90 on blood pressure. So we've managed all the threats. We're going to get an immediate transport decision. We're going to log roll him, check his back, make sure there's the bullets out of the head. It's not anything like that. We roll him, put him on the backboard. They're going to secure. We're not going to be able to use a C collar because of the gunshot wound. So we're holding pressure and he's still maintaining C-spine. We get him loaded in the ambulance. We're on level 1. Once in the ambulance, I'm going to start an 18 gauge both ACs. That'll just be tourniquet, clean aseptically, insert 45, drop it, lock and a flush, flush it, and we're good to go. We'll come back up to the airway, accept an I-gel, going to be facilitated intubation, so we're good to intubate. I'll go ahead and get vitals while I'm setting up for my intubation attempt. I'm going to use probably 7.5 tube tamer. I need a flush. I think the 10 mil syringe. I'm gonna have my lube, my bougie, stylet. Get everything set up. Mac 3, Ornoscope. Make sure the light works on it. Make sure I have oxygen. I want suction available and ready. So while I've got all that, they've got vitals. So right now he's 90/50, 130 pulse. We'll say 140 pulse. SpO2 is 90 on the I-gel, and capnography is 28. At this point, I'm gonna have them pre-oxygenate him a little bit with the I-gel. I pull the I-gel. I'm gonna up in the mouth with my left hand, Mac 3. I'm gonna insert above the vallecula, pulling it up, exposing the vocal cords. We'll slide the tube with the stylet through the vocal cords. 2 to 3 centimeters. Put that down, hold that, hold my stylet. I'm gonna secure it. I'm gonna inflate my bulb. Once I inflate the bulb, she wants to watch TV. Once I inflate the bulb, I'm going to put my tube tamer on there. We're going to go ahead and put it back on the BVM, 15 LPM on oxygen, and then we would have, with the upper airway, we would have been suctioning if there had been anything that was in the airway. Kind of hard to visualize, but if you see anything, we're going to suction. So in suctioning with that, we can use the salt method, which would just be switching the hands and holding the suction down there while we do it. So we got the airway is secure. We're going to check lung sounds. We're going to confirm the tube with the moisture in the tube, condensation in the tube. Confirm it with chest rising fall. We have lung sounds. We're gonna have diminished on the right side. And capno. We're gonna see a little bit of spike in capno. So we see our spike in capno. We do notice the diminished lung sounds. So we'll go ahead and dart the chest on that. If we've got human. And then, so we'll do that. I wasn't in the lab, so hopefully my next lab I can learn that. So once we've done that, we've taken care of the chest. We have the airway. We're going to do a little more thorough assessment. Just go through anything else. Do another set of vitals. So our next set of vitals, we're at 80/40 and 160 pulse. So we would initiate shock management. So in that, I want fluid replacement. I want to contact the hospital, make sure that we're ready to receive. I want to get blood on board if possible. But right now we'll do normal saline at 250 boluses. And we'll see after every 250 if we get a pressure change. And we want to manage it to 90, at least 90 perfusing. So we would check the perfusion right now, gap refill. We're still good right now, but we aren't being compensated. And it seems like we're going out of compensated. So we would want to start our fluid replacement. We have 2 IVs. Another thing I'm going to do with fluid replacement is I'm going to go TXA. We've got a lot of bleeding. We have it managed, but in the face, around the airway, I'd rather have that taken care of. So 1 milligram per kilogram, say 70, 80 kilograms, so 80 kilogram or 80 milligram of TXA. There's that. We've got saline running. We're going to reassess vitals every 5 minutes. We're going to give him a blanket, and we're going to lift his feet. Yep. So, and then we'll do our secondary assessment, go through everything a little more thorough depending on how much time we have. The main thing I want to do is manage the airway and that chest. So manage those 2 things. And like I said, the darting, I'm not checked up on that skill yet. So, and he was unconscious, so we didn't worry about drugs with intubation. We did have a pulse. We had a pulse the whole time. Wasn't something we worried about. We definitely get, we would have had pads or a 12 lead on. Take care of all that. We look for abdomen rigidity, anything go down. Be checking eyes, like the other side of the head. We'd be looking for cranial fractures. We've assessed the chest. We've taken care of that. All 4 region of the abdomen, pelvis. So we'd be checking that, femur, TMS, all extremities. We don't see anything on the arms. Obviously they're trauma naked at this point, prepped for receiving hospital. Yeah, probably missed something, but that's it.